Professor Dr. Rohit Saxena from RP Center, AIMS, New Delhi, is one of the best pediatric ophthalmologists in India with a large number of publications and national and international presentations. And Dr. Rohit will be speaking on recent advances in ophthalmology, recent advances in pediatric ophthalmology. Over to you, Dr. Rohit.
Hello, everybody. Thank you, KSOS, for giving me the opportunity to be a part of this wonderful conference. And thank you, Srini, for giving me the opportunity to be a part of your wonderful IC. So I will be speaking on advances in pediatric ophthalmology and strabismus. And really, thank you, Srini, for giving me an opportunity to talk about this, because frankly, pediatric ophthalmology and strabismus is actually one of the most exciting and evolving subspecialties of ophthalmology. There is so much changing in the past few years that I really cannot speak about everything, and I'll try and limit my talk to the key changes that are happening in strabismus surgery, how we are managing different scenarios which are difficult, myopia therapy, and the new and very, very important thing for our children is how to manage and prevent childhood myopia. So I'll quickly run through some of the evolving managements and difficult scenarios on the third, fourth, and the sixth nerve palsies and Duane syndrome, some which are very new and very interesting. So increasing options in third nerve palsy. Now, initially, we really did not have much of an option, and it was more or less telling patients that there's nothing we can do about it. And actually, we're glad that there was associated ptosis, so patient really would not feel diplopic. But now we have some very good options available in the form of globe fixation procedures to the medial wall, which many of these modifications we have described from our center at RP Center. And of course, the transposition procedure where we use the lateral rectus transposed medially to bring about some very good effect. So these are the steps of the medial wall periosteal anchor, and we use the precurruncular approach described from our center, where the precurruncular area is used to expose the medial periosteal wall. Ethibond or non-absorbable sutures are passed. The conjunctiva is open next to the muscle, and a tunnel is made from the periosteum to next to the muscle, and the sutures are brought there and tied. Now, this is one of the results that we got, and it's an extremely strong and extremely effective procedure, and you can actually almost predict your final position of the eye and therefore correct large angles. The newer thing that we are now, what we have seen is the medial transposition of the split lateral rectus, which is transposed medially, and we actually augmented the procedure with posterior fixation sutures to get some very good outcomes. So here is a child of complete third nerve palsy, which you can see has very little medial rectus function. But the moment we operated and we split the lateral rectus and transposed medially, you can see some very good results. And these are true for a lot of cases that have now been done around the world. So this is now becoming a very, very popular surgery. Sometimes when you have a vertical deviation along with this horizontal deviation, you can actually do a full transposition from one of the sides and get some very good correction. Like in this case, hypertropia is corrected by shifting the lateral rectus from underneath the globe, and there is no splits. It's the entire muscle shifted, and you can get good vertical as well as horizontal correction. We know that these transpositions are fixed transpositions, and you cannot actually adjust them. So we actually worked to make them adjustable. So we changed the way of surgery to adjustable sutures, or used adjustable sutures in this medial rectus transposition to get, again, very good correction for both horizontal and vertical deviations. In the sixth nerve palsy, of course, a lot of options are there, including transposition surgeries, but among the new ones would be a partial vertical rectus transposition along with a posterior fixation suture and Nishida's vessel sparing transposition, which are now again becoming very popular. So this was a patient with a very large esotropia because of a sixth nerve palsy post-traumatic, and you can see significant deviation and significant abduction deficit, and we did partial vertical recti transposed. So we used half of the lateral slip of the superior rectus and the inferior rectus to the lateral rectus, as well as an adjustable medial rectus recession to get a very good correction. Another patient, you can see a large sixth nerve palsy with very little lateral rectus function. In this case, we did the Nishida's procedure. This is nearly a vessel sparing procedure, although some amount of vascular compromise can occur because the sutures would actually go around the vessels sometimes unless you're able to spare them in your passage of sutures. And the vertical recti are now transposed towards the lateral rectus without these recti being disinserted and tied close to the lateral rectus. Therefore, their force is transposed for abduction, and when combined with a medial rectus recession, which can be done adjustable, you can get some very good alignment in primary gaze. Superior oblique palsy, among the new things that have been described, is the anteronasal transposition by stager, which helps to correct a lot of torsion that may be present in these cases. So if it's a vertical deviation that is more than the horizontal deviation and then torsion, then we would probably think of an Elliott and Nanking procedure, which would bring the eye down. But where there is significant excyclotorsion and SO underaction, you can do an anteronasal transposition and get some very good results, which can help to correct the torsional component also. And in this case, you can see an improvement in the torsion in the fundus. You can see pre and post. Another difficult situation is in exud ones. Now, among the new things that we do are periosteal fixation of the lateral rectus, getting good alignment, and that can be combined with, again, partial or full tendon transposition of the vertical recti to the lateral rectus, site of the original lateral rectus, that can again give us good correction. So the lateral orbital wall fixation of the lateral rectus along with split or half vertical recti transposition. So the lateral rectus is now tied to the periosteum and its abnormal innervations have been removed, and the consequent esotropia is corrected by doing an adjustable partial vertical rectus transposition, giving very good correction. So here you can see severe co-contraction causing upshoot, and you can see post-operatively some amount of abduction also because of the partial vertical rectus transposition that we have done. Now, imaging has changed strabismus management in a great way. Imaging technology has actually made us understand and also help in the planning. Dynamic MRIs can help to pick up functional contractility problems. High resolution MRIs can help us to pick up the extraocular muscle pulleys and help us in their surgery and effective management. And anterior segment OCT has been shown to detect muscle insertions in previously operated as well as new strabismus cases. So this is a case of high resolution MRI imaging in a Mobius syndrome where you can see the absence of the left seventh nerve and absence of bilateral sixth nerves. Dynamic MRI, you can see the lateral recti and the different muscle contractions when the eye are moved while the MRI is going on. And this is an ASOCT, anterior segments OCT, where you can actually measure where your muscle insertions are. Therefore, you come across a patient who has been previously operated, but you do not have the records. You can actually use the SOCT and get a very good idea about the position of the muscle and therefore plan your surgery. Lipid therapy is another place where a sea change has taken place. From these iPads, we have moved to iPads. And occlusion therapy, although still the gold standard, is now slowly giving way to technology that in the form of either video games to make Activision therapy, or in the form of dichoptics, where we are binocularly stimulating the eye, the amblyopic eye, more than the normal eye, so that we can correct for the amblyopia. And these are getting better and better with virtual reality. We are actually making amblyopia therapy actually enjoyable to the child as he is taking or getting better in his vision. And finally, managing childhood myopia. In fact, in India, almost say 10 years ago, childhood myopia was really not a cause for concern because, I mean, as ophthalmologists, we were actually we were happier looking at prospective candidates for refractive surgery. But truly, it's a major loss to a generation of children who are now becoming myopes increasingly. And in India also, the attention came through one of these papers published in ophthalmology, which showed that by 2050, virtually 50% of the world's population is actually going to become myopic. We did a meta-analysis published some time back in which we showed that despite the wrong concept or the misconception that in India there's not so much myopia, we found an overall prevalence of 7.5% over 4 decades, and the prevalence was 8.5 in urban and 6.1 in rural, and an increase in the last decade in rural areas was from 4.6 to 6.8, showing that the rural areas are increasingly catching up with us. So the key things that have changed is now our understanding of how to prevent myopia, identify the pre-myopic child, increase awareness among patients and parents, modulate the risk factor, reduce their near time, increase their outdoor activity. These are among the key interventions to prevent a child from developing myopia. And a child who already is myopic, you can give spectacles and soft contact lenses, particularly multifocal soft contact lenses, orthokeratology, progressive ad lenses, and now atropine, which is now approved and marketed in India for preventing progression of myopia. This is one of our papers in which we evaluated the role of atropine, and we found it to be very effective in preventing progression or slowing progression. It was a randomized controlled trial from 3 centers in India. And finally, like I said, there are a lot of options, including atropine, orthokeratology, multifocal contact lenses. One of the key things of increasing time outdoors is one of the most important interventions we can tell our children. So prevent onset by increasing awareness, improve the eye habits of children, encourage outdoor activities now that we are opening up, minimize internal handheld devices, small devices, take frequent breaks, read in natural light if possible, maintain a good distance. And we know that outdoor activity, atropine, contact lenses, and ortho work. So essentially, again, pedophthalmology is among the most exciting and evolving fields, and we are looking at multiple advances as we cater to 25% of the population and more than 40% of our general OPD. Thank you again. Thank you, Srini. Thank you, KSOS, for giving me the opportunity to be a part of this wonderful conference. Thank you very much.
Thank you, Dr. Rohit, for that exhaustive presentation on recent advances in pediatric ophthalmology.